So with that, I will introduce Dr. Elizabeth Ablah. She has a lot of initials after her name. PhD, she has a master's in public health. She is the associate professor in the Department of Population Health at KU Med Center, and she's accompanied today by our health officer, Dr. Menz, to talk us through her presentation. So, Dr. Ablah, please.
Good morning, Doctor, and welcome to Sedgwick County.
Good morning. Thank you so much. Mr. Stoltz, thank you. That was very thorough and a great introduction to the topic. I'm Elizabeth Ablah. I'm now a professor. I just got promoted. I am at the University of Kansas in the Department of Population Health at the School of Medicine here in Wichita. And I'm going to tell you a little bit about the proposals that have been received up to this point. And before I do, I want to get a little bit of background, just to provide a little bit of a description as to the context. So when we get into some of these proposal and some of the terms that this makes sense. So when we talk about testing for COVID, we need to think about collection and we need to think about analysis as two separate components. So for collection methods, the CDC recommends the following types of specimens. Nasopharyngeal is the one that is the most commonly discussed and was promoted as the gold standard. It is now, these are all considered acceptable. Notice that saliva is not on this list. There are three types of tests, and I want to briefly describe the three. There are two that are for diagnostic purposes. That's viral. This is also known as molecular, also known as PCR. And I'll describe each of these just a bit. There's also an antigen test, and I'll describe that a little. And then those are the two that are considered diagnostic. There's also an antibody test, but that is not a diagnostic test. This is also known as serology. So we'll discuss that as well. But there are two that are for diagnostic for the virus. So let's start with viral. So viral, also again, molecular or PCR. A sample of mucus is taken from the nose or throat, and these specimens are delivered to a lab. This is what we are most familiar with, I believe. About 3 to 7 days is the average turnaround time for the entire process, not just the lab. An antigen test. This was approved in May, and this is also using a nasal cavity, using a swab. This is considered a rapid test. It can be in less than 2 hours even. The advantage of this is that it is less uncomfortable for collection purposes. And the other advantage is speed of the test. So that is a real advantage. Antibody, again, this is not a diagnostic test. This is a blood test, and this identifies if there has been any type of antibody that has been generated in the body as a result to fight off the virus. So what can be determined from this is if the individual has had the virus at some point. It is not an indication of whether the person has the virus currently. So in terms, again, of diagnostic, it does not serve that purpose. Okay, so when we get to analysis methods, viral, again, the PCR is what we talk about the most. It detects genetic material. So it is really it's a solid indicator of whether the virus is present in the body. It is PCR because it's polymerase chain reaction, and it amplifies the viral DNA. So if it's there, it's easier to detect because it basically shines a bright light on it. And a positive test means that the person is infected. An antigen test, this is different. This identifies proteins to determine if the virus is present. It is less accurate than the viral or the PCR test. And it is not officially FDA approved. there's that. The antibody test, again, it's a blood-based test, and it uses the protein as an antigen, so it's similar in that way to an antigen test. Okay, so a few considerations. Viral, again, the gold standard here is the real-time reverse transcription polymerase chain reaction, or PCR. It is a diagnostic test. It is the most common test used for COVID-19 for diagnostic purposes, and it is considered the most reliable. And it can produce false negatives if it is not collected correctly. That is why we want to make sure that we have folks who are collecting the samples correctly. An antigen test, also diagnostic. It doesn't necessarily identify all active infections because it is not as sensitive. And I'm going to talk about what sensitivity and specificity are. As Mr. Stoltz referred to, we're looking for accuracy. We want to make sure that we're actually testing for the virus. Positive result from the antigen test can be accurate, but there is a higher chance of false negatives. I'll say that again. There's a higher chance of false negatives with an antigen test. So we'll talk about what that means and the implication for that. A negative test, and this is really an important point, negative tests or negative result does not mean that it is a negative. It needs to be, and this is in all of the descriptions for an antigen test, any type of antigen test, the description says that you have to confirm it with a PCR test prior to making any treatment decisions or to prevent possible spread. And so what's that next step? PCR, right? So if you get a negative test with an antigen test, a negative result, from an antigen test, that does not mean the person is negative. It needs to be redone with PCR analysis, which is the initial test that we were talking about. So, please.
Yes, I'd like to go ahead and just, you want us to talk back and forth when we have questions as you're
I would be
presenting?
happy to talk back and forth.
Okay, so this is kind of what I was referring to yesterday, and I don't know if you heard the meeting yesterday or not, but I didn't describe it exactly right because I'm not a medical professional, obviously, but the antigen test, if someone has symptoms and they have the antigen test and it comes back initially, again, with rapid response, the negative result, they will run that sample, the same sample, through a PCR process. Is that correct?
That is a question I do not have the answer to. I don't know what the local process is, if it's the same sample or if it's a different sample.
Okay. Well, I talked to some people yesterday afternoon, and again, once again, I don't know exactly what the practices are here in Wichita, but I'm hearing that this is something that is done, and Dr. Norman, I guess, also talked about this a lot at the KDHE briefings as well. But all right, well, thank you for the information. I appreciate that.
Sure. Thanks for the question. Okay, so an antibody test, that should not be used to diagnose COVID-19. It just doesn't diagnose it. It can miss the active infections because it takes time for a body to create those antibodies to fight off the virus. And it can show whether the person has had the virus at some point in time. So some tests do produce high numbers of false positive results. And the real purpose and the importance of the concept around the antibody test is the reason it's so complicated is that we don't really know the salience of the antibody test at this point because we don't know what it means. If you have had the virus, the scientists don't know yet if that means that we're immune to getting the virus again, or if you're able to help other people, for instance, like through donation of blood. So it's a really big question right now as to what it actually means. So antibody tests, not diagnostic, and have some large questions around them. So let's talk about that accuracy that Mr. Stoltz was referring to. So how do we define accuracy? Well, in this type of a world where we're looking at epidemiology, we're trying to understand this condition, We think about positive and negative in terms of having a condition, or in this case, the virus. And then we also have positive and negative in terms of what the test is. So if we're wanting to understand, for instance, the benefit of PCR analysis, or the accuracy of PCR, or the accuracy of an antigen test, we often have this 2x2 table that we generate. And the idea of this is that we are looking at those who have the condition and those who do not have the condition objectively. And then we're trying to determine whether these folks have the infection or not, or the condition, through a test. And that is a positive or a negative result. So if we see, let's just look at those folks who have the condition. Those folks who have the condition and they test positive, that's considered a true positive. This makes sense, right? Those who have the condition and test negative, that's considered a false negative. Now, in my opinion, from a population health perspective, this is the most dangerous, because we have somebody who has an active infection and we're telling them, nope, you're fine, you don't have anything. So that is a false negative is extremely dangerous. Now let's look at those who do not have the condition. So folks who do not have the condition but are tested positive from the test, that is a false positive result. Whereas a true negative result is somebody who doesn't have the condition and obviously tests negative for the condition. So does this make sense generally? Okay. So when we calculate sensitivity, we're only looking at the column on the left-hand side. So among those who have the condition, we're looking at the true positive, where the denominator is all of those who have the condition, so A plus C. So if we're calculating it, which I won't make you do, it would be A on top of A plus C. So that's how you calculate sensitivity. We want the test to be sensitive because we want to be able to detect it if it's there. So in my opinion, that's the best, if we can get something with very strong sensitivity. Let's talk about what specificity is. So specificity is very similar in that we're looking at a column and we're only looking at those who do not have the condition this time. And this time we're looking at the true negative as what's on top, so D, and then that is over B plus D. In other words, everybody who does not have the condition. Does that make sense? Okay, so specificity, I like to think about this as I'm sick. I'm going to the doctor, and the doctor gives me a test, and it's not very specific. So I might have the flu in reality, but the test says, yep, you have COVID. Does that make sense? So specific helps us discern what is the actual problem, whereas sensitivity is, are you sick, basically. So that is sensitivity and specificity. In an ideal world, we'd like it to be 100% for both, right? That would be lovely. And quite frankly, I believe that's what Mr. Stoltz was referring to, that we're waiting for this technology because there are new tests coming out, as you know, all of the time, and they really have some spectacular results that we're continuing to prove on the science. So with that as a background, I'm going to launch into the two proposals that have been submitted for the CARES Act funding. One is from Wichita State University, and that is through their lab. And then that is the MDL, Molecular Diagnostic Laboratory. And then the other that is on the right-hand side is Ascension Via Christi. So I will consistently have Wichita State on the left and Ascension on the right. So it's consistently presented the same way. So when we're looking at the applications the objective for Wichita State University is very consistent with the objective for Ascension. That is to provide high throughput, low cost, quick response COVID-19 screening. So we want to be able to figure out, do we have it? Ascension, very similar. They indicate that by combining Ascension via Christie's expertise with financial support through of Sedgwick County through the CARES Act funding, we believe we can better serve our community through this pandemic. So what are the proposed activities? They're very similar. Both obviously involve testing. You'll see here that the MDL, or Molecular Diagnostic Laboratory at Wichita State, is what they're wanting to create as a regional asset for the county. And you will see here, this is the first indication from Wichita State of one of the many questions that have arisen from both of these applications that will be up for your consideration. And that is, they're proposing a prepaid bulk rate of $60 per test, and that's something I will come back to in a bit. Ascension is wanting to purchase equipment and install it in addition to also doing the testing. So that's just a little bit different because they are requesting some funding for an equipment for a PCR analysis. Okay, so the question of, are these accepted methodologies that they've proposed? I'd love to be able to answer that, and yet this is a second area that the applications are a little bit lacking. Wichita State University at this point in their application have provided information to indicate that it is going to be their real-time reverse transfer PCR analysis. And they have indicated that it is sensitive, and they have all of the different types of collection strategies that are approved by CDC, Centers for Disease Control and Prevention, in addition to saliva testing that they're wanting to then also launch into. They do not indicate what the machine is, so that is a limitation because I can't give you information about that. I will note, however, that they had originally in their first proposal asked for funding for that equipment, and they went ahead and purchased it anyway. They did not wait for that. Ascension via Christie did propose this new Alinity M system and its Abbott system, and I will talk a little bit about the sensitivity and specificity of that. So you'll see there's information again. Wichita State University says it's sensitive, but they didn't give us the information to know how sensitive it is of a test. And they hint at also specificity, but again, we don't have that information. With Ascension, their test that does have information they propose in the website accurately, so this was not inaccurate on their part, indicates that it's 100% sensitivity and 100% specificity. Research suggests that it's actually 93%, so we went to the academic literature and identified that sensitivity there is 93%, specificity is 100%. Again, as with many tests, they do indicate that negative tests do not preclude this and should not be the sole basis for decision making and treatment. Okay, so some logistics. When it comes to Wichita State, they are proposing that it be a little bit more community-based. So they would like to start with having funding to go to providing materials for healthcare providers, so that they are off-site. So in their own facilities, they are going to be collecting samples and sending them to a laboratory, to the Wichita State Laboratory. And they have also proposed that if the demand increased, that they would be willing to also offer a mobile drive-through. Ascension has proposed a walk-in testing plan, and they have a design concept for that. In terms of the testing capacity and expected output for the equipment, Wichita State University, the capacity is about 5,000 tests per week. And they have also indicated that they could add additional shifts. Both institutions offered a Monday through Friday schedule, but Wichita State said that they would be happy to ramp up if needed. The expected, so that's the capacity of what the machine can do on that schedule. Expected, they're proposing here that it would be about 1,000 tests per week and that they would gradually increase that over the first few weeks. This is important because there is a point at which in this application, Wichita State actually proposes that it's going to be significantly less, and we're also going to talk about the timeline of making this happen. Because Wichita State is very clear in their proposal that they are proposing 100,000 tests. So 100,000 tests, and a reminder that this funding ends on the 30th of December of 2020. Ascension capacity is what they've provided. It turns out to be about 5,400 per week. The expected, they're proposing about 900 per day, so that's about 4,500 per week. So this is a planned monthly output of 18,000. However, later in the proposal, Ascension indicates that their output monthly will be 20,000. So some inconsistencies as to what the total output, and there is no information. Ascension does not indicate that they plan on having a certain number of tests over that period of time through December. The results, it's very important, obviously, that the results are shared with the people who have been tested so that they know their results. Wichita State, when we asked them the information about how the results would be shared with those who are tested, they indicated that the results would be sent to the ordering physician or the healthcare provider and through a text to the patient, and that they will know as quickly as possible. Ascension reported that their testing results would be provided to the county and that results would be provided electronically in aggregate. They did not address the question directly as to how the patient or if the patient would be notified. So remember, they were the the walk-in clinic. Okay, so who will be tested in these proposals? Wichita State says that it's whoever the healthcare provider suggests is needing testing, whether they're symptomatic or asymptomatic. That's up to the healthcare provider. And that is pretty much consistent with Ascension, other than the fact that it's a healthcare provider. This would be symptomatic and asymptomatic, that it would be determined on one's own. Both indicate the population served would be all ages. In terms of when we asked how do you plan to serve those in greatest need, Wichita State's proposal indicates that they would offer the test at cost to make it as feasible for as many people as possible, and Ascension indicated that they would accommodate populations, all populations, and their facility would be ADA compliant. The turnaround time is consistent for both applications, for 24 to 48 hours. In terms of where the analysis would be conducted, both plan to be in the county in Wichita. Wichita State's analysis lab is at South Oliver, and the Ascension lab is through AMS, which Ascension owns. In terms of who pays, this gets into some of the interesting points of these proposals. So Wichita State, and this is verbatim from their proposal, the proposal seeks CARES funding to provide bulk pricing for prepaid. Again, prepaid is a question mark that you need to be cognizant of as to whether that's even possible with CARES funding. Prepaid testing services to be conducted in high throughput facility, and that CARES funding will pay for the testing kits and laboratory services to process and report testing outcomes. So the way that this is all covered through CARES funding in the application, in Wichita State's application. In terms of Ascension via Christie, they indicate that there will be a test fee of $55 for the test process, for $5.36 for swabbing, and that those fees would be billed to Sedgwick County. So that's, again, another question that is raised as to what is this in reference to? Is this in addition to the CARES funding, or what the billing looks like? Also to note, Ascension Via Christi also has later in their budget that the test is $66, so $60 for the test processing and $6 for the swabbing. So it's inconsistent within the same proposal. We asked what their plan was to involve Sedgwick County Health Department. And Wichita State says that all positive results will be reported to KDHE, and that they'll work as requested with the Sedgwick County Health Department. Ascension Via Christi indicates that we've had an 8-year track record and will continue to collaborate. The expected outcomes, what each of them are expecting will occur. Wichita State has a goal to suppress the COVID to less than 1 daily new case per 100,000 people, which is a relatively common metric to get into the green zone, according to Harvard. Increasing testing capacity, they propose, will address the following problems around making basically our economy stay open, businesses, schools, and public services. Ascension Via Christi proposes metrics that are more specific to their facility in terms of specificity of the equipment and safety. And they do indicate that they are proposing access to testing increases 50% greater than baseline, and they indicate that that baseline is obtained from Sedgwick County. They do not, however, indicate what that date is or what that number is, so that is also a point that would be useful for clarification. In terms of monitoring outputs and processes, we asked them, how are you going to be evaluating the process throughout? And they're monitoring at Wichita State the daily testing throughput, the test turnaround time, and also the percent and number of positive and not detected cases. Ascension has information about their quality improvement plans and how those same quality improvement plans will be implemented and reported on a monthly basis to Sedgwick County. Very similarly, the evaluation plan is the same as the expected outcomes for Ascension, whereas Wichita State indicates that at 12 months after operating, they plan to do a 360 review. In terms of compliance, there are a number of factors that need to be considered for compliance, as you know. CLIA compliance, HIPAA, and privacy, confidentiality, and whatnot. Wichita State, verbatim, provided this information. Ascension included this information in addition to some human subjects protections, which is not applicable because it is not research. We asked them to describe their plans for sustainability. So they've purchased the equipment, or they plan to use these resources. What are they planning on doing with the equipment after and the resources after? Wichita State University reports that they will add testing capabilities based on the needs of the community. This is another point that I'd like to elevate as a potential question and conversation point. They would like to provide testing all throughout 2021 and 2022 as needed. And that is a question from my perspective as to where are they going to be receiving funding for that, because the funds need to be spent, the CARES Act funds need to be spent by the 30th of December for 2020. They also propose that the equipment can be adapted to be used for other viruses like influenza. In terms of Ascension Via Christi, they have indicated similarly that a lot of these, the equipment, for instance, that they're proposing that's part of their application can produce valid results for 7 to 8 years, and that they plan to continue with their Joint Commission accreditation along with other staff competencies. Okay, so the bottom line in terms of budget. So $60 per test, very clear throughout Wichita State's application. This includes personnel, equipment, materials, other costs, everything that was asked for. It is all $60 per test, and that is going to be covered by their lab revenue. They are proposing 100,000 tests, and they do indicate this little caveat that's in italics and bold, that the county will be able to distribute and price the test at their discretion based on income, insurance, etc., and that any revenue will remain at the county. Ascension indicates, again, two different places. One is about a little bit more than $60 overall, and the other is $66 for the materials, for the testing materials. But then also the equipment that they're requesting is more than $1 million. So you can compare the two costs here, $6 million versus $7.6 million. Wichita State had proposed a number of partners and stakeholders that were a part of this application, and I will note that Ascension Via Christi is one of those stakeholders. And Ascension Via Christi noted the AMS Labs as a partner. In terms of licenses, both are going to be operational. CLIA lab certification for Wichita State was applied for in mid-June, and Ascension Via Christi has all licenses for their hospitals, clinics, and labs. So a reminder, the activities that are proposed, Wichita State is wanting to have a high throughput, low cost virus screening, and they're wanting also to make sure that this is in the community, but they will provide an additional service if needed for a mobile drive-through. Ascension Via Christi has the establishment of an operating site for swabbing and collecting samples, but they're also wanting to purchase and put into operation one of the PCR tests that they're hoping for that equipment to be purchased. Neither organization identified any organizational duplication of efforts or conflicts. Both proposals offered experts and references, so if there were some questions, there is that as a possibility to follow up. In terms of in-kind contributions, Wichita State has already committed cash to fund equipment, supplies, and startup staffing. I mentioned earlier that in the original application they had asked for equipment. They went ahead and purchased that equipment. Ascension Via Christi, the proposal does not include in-kind contributions, and this is the verbiage that they've provided. Just in a little housekeeping in terms of details, there were also work plans that were requested and curricula vitae to get an idea of the key personnel. And we also asked for the proposal to be limited to 4 pages. Wichita State complied with the 4 pages, and they did provide a sufficient work plan and CVs for all personnel. Ascension did not comply. They doubled the number of application pages, and they did not include a work plan, nor did they provide CVs. The reason that is important is that there is a question that is elevated in reviewing the work plan for Wichita State. Because they've already purchased this equipment, they are going to need to test the equipment. They're going to need to do all sorts of different certification processes and validation processes. And as a function of that, it takes time. Again, the funds need to be spent by the 30th of December. So looking at that ramp-up time, it's an important question. On the other hand, Ascension Via Christi has not yet purchased the equipment. So there's going to be a ramp-up time for both applications, for both organizations. That is undeniable. So just a final point that I'd like to make when it comes to consideration of these applications, and there's a lot I know to consider here. There is no consensus among experts and researchers around a raw number of tests or tests per population. We don't have any sort of best evidence around that. But what is becoming very clear among a number of organizations, Johns Hopkins University and Harvard amongst them, and also the World Health Organization, is that testing programs need to be scaled based on the size of the epidemic, not necessarily the size of the population. So when we see positive cases and we see an increase in positive cases, that means we need to have an increase in testing. So that is the most reliable way, and I know that is contrary because we think, what's the hard number? We need the number. How many people need to be tested in order for us to get this? And I get that, and obviously we need to know. We need to be able to get a number, but what needs to drive that number is the percent of positive cases from the tests, assuming that we're continuing to test in a broad and valid way. The World Health Organization, or WHO, has issued guidance that suggests that positivity rates need to be 5%, actually below 5%, for at least 14 days prior to relaxing any social distancing measures. So less than 5% for at least 14 days. So some additional numbers, because I know this is of interest to get some testing numbers. The suppression goal for Kansas, again, according to Harvard, is 433 daily tests per 100,000 population. 433. So for Sedgwick County, that is about a little bit more than 2,200 daily tests. And that is my presentation. I'm happy to answer any questions.
Okay, thank you, Doctor. Quite a bit of information, obviously. Thanks for the comparisons. It looks like I tried to do little pluses and minuses as you were talking, so it seems a little bit equal evaluation from my perspective, but seeing it for the first time for 20 minutes here is very difficult. Eventually, maybe there'll be some other questions specifically, but eventually, are you going to be able to recommend what you would think we would do, either one or the other, or a hybrid of both, possibly?
Excellent. I would be happy to do that. What I would like to do, if possible, is have an opportunity to ask Wichita State University some pointed questions, and also the same for Ascension via Christie, so that we can get a little bit of clarification on some of these, so that we're not just guessing.
Okay.
And as a result of that, we would like to make I'd like to be able to make an informed decision to be able to provide to you as a recommendation.
Okay, well, and you did mention a number of times in your presentation that the information is a little bit, there's some gray areas, but
Right.
It's great information overall. So, okay, a couple of questions probably. Commissioner O'Donnell?
Thank you. So my question would be, with the equipment lead time of 3 months, did you ask Wichita State what their lead time was as well?
That's an excellent question. So Wichita State was actually the one that did provide the work plan, and that's what really led us to start considering what the work plan would be for Ascension via Christie. So yes, we asked for that timeline. Ascension did not provide it. Wichita State did provide it, and that was really what caught our eye. So if you, I don't know if you have the applications in front of you, but on page 15 of the Wichita State plan is their work plan. And you'll notice that they have the soft opening for an internal client on the 16th of October as their proposed date. A number of different, there are all sorts of lab tests and CLIA certification processes. But it is not until the first private test is available, and here they limit this proposed to 100 to 200 per day by the 26th of October. So that's where the timeline gets to be really funky, and there's not going to be a way around that with these two applications. because they both have the same deadline, obviously, and they both don't have the materials yet.
Yeah, and I do think there's going to be another application as well. I know Heartland Research has been looking at one and trying to expedite that as well. Because with these tests, obviously our whole goal is to make sure that we're not spreading it, and if we had them ready for school districts to use primarily, we look at just the outbreak we had at the jail. So I think it's critical that we try to speed that up if at all possible. But like you said, every community in America is trying to.
You got it.
Is in the same thing. But I was under the impression that WSU, being a university, had quicker access to getting some of the machines and materials.
So it's a great question, and they have purchased the equipment, as I've mentioned, but at this point, from what I understand, they have not received it. And so this is obviously a proposed work plan. It might be later, it might be longer, or earlier
Yeah,
or longer. Yeah.
Thank you. Thank you, Doctor.
Okay, well, we get some more dialogue. Commissioner Howell has some questions.
Yeah, thank you, Mr. Chairman. Just to clarify, so in either one of these cases, does the test site handle all of the interface with the patient or the person being tested and communicate back with them? So this is handled completely, if you will, within the testing efforts by this organization?
That is a great question, and no. Let's see if I can find this. The information is from Wichita State. The test is going to be conducted by the provider, and the lab at Wichita State will process the information. They will provide the information directly to the provider, and they're proposing that there will be a text or some type of, I think they indicate, a text message to the patient so that they know their results immediately. Whereas with Ascension, they did not address how the patient, the individual, will be receiving the results, but they indicate that the county will receive this by fax or hard copy, and that there could be an aggregate report. Again, something we'd like clarification from Ascension on.
One of our biggest challenges, of course, is getting our test results, the number of days down to something that's useful, and that's probably one of the number one things in this entire proposal is how long it takes to get the results and how fast we can communicate back to that person. And the other part of this, which I think is most important, because I think the numbers are mostly the same, except for there's one number that's significantly different, and that's on page 11 of the presentation, but the capacity is drastically different between the two proposals.
So potentially, again, we did not get the type of data that we would have liked to have received. So Wichita State indicates that they will plan to start with 1,000 tests per week, and that they will ramp up. As I just mentioned to Commissioner O'Donnell, in their timeline, they say that they might need to start with 100 to 200 per day as a sort of a soft start. So how these numbers would actually be worked out, and a question even to add on to that, do we even need these numbers? Do we need this level of capacity of what both of these organizations have proposed? So that is another a point for your consideration, that we might not need 100,000 tests, for instance, in a span of 2 months. It's a question.
One other question is on page 19, bottom of the page, there's a proposed partners slide.
Uh-huh.
I see Ascension's actually on both sides of that slide.
Yes.
So they're going to be partners regardless of whether they do this through Via Christi or through WSU.
Yes, that is correct. And that is Ascension, whereas their Ascension's partner is the AMI labs. Or, excuse me, AMS labs.
Use the word stakeholder. Can you please explain the word stakeholder?
I would love to. So generally, a stakeholder, from my understanding, although this was not described in the application, is someone that tends to have a stake in the matter. So whether they are a partner, a fiscal partner, if that has not been described. So again, I would love some clarification on that as well.
Thank you.
Okay. Commissioner Dennis?
Thank you. Doctor, thank you very much for being here and for the analysis that you've done so far. We sincerely appreciate it. Just a couple questions. You've indicated you still need a little bit more data and a little more answers from each of these different proposals. When can we expect that a decision will come back to us?
So I would, what we have discussed, Mr. Stoltz and Ms. Byrne and some others, we have discussed returning back to the two applicants and potentially third, and discuss with them the questions that have been raised here today and with our team, and that we would like to then return to you potentially with an additional, a recommendation, potentially as early as next week. Mr. Stoltz?
We have meetings currently scheduled with both of these entities on the calendar. The goal would be perhaps another special meeting, another special meeting next Thursday or Friday to keep this moving.
Very good.
Well, that's pretty quick.
Another question I have is that you gave us a list of the different types of tests at the beginning. Will each of these different proposals be able to do all of those different type of tests?
Great question. No, it is not. It is at this point, Ascension is proposing PCR and Wichita State is proposing PCR, which is considered the gold standard.
Okay, but later on, if we need to do some serology as this continues to develop, the machines won't do that?
That is correct. Not to my knowledge. That there might be some machines that do that, but PCR analysis is different.
Okay, and none of them will do saliva then? It's just the nasal pharyngeal test, or are there different ways of doing this?
Yes, actually, the saliva tests, there is research that has been done where saliva tests are analyzed with PCR analysis.
Okay, so we can do that test in the future. Okay, well, I guess my last comment really goes back to the county. One of the biggest problems that I see in the county is that the back end of this is where we're kind of lacking. We can get all the tests done, but how do we then notify the folks? Now, the one thing I noticed is that they were going to send out text messages from WSU, but I think we're kind of overloaded right now trying to follow up with people. We would love to see greater testing, but we need, I think in Sedgwick County, the capacity to deal with that additional testing. So it's not so much a question for you, it's more of a question for Sedgwick County of with all this additional information, how are we going to deal with it?
That is a good question, Commissioner. We have two trains going down the track there. Dr. Ablah is describing in some pretty good detail the scientific portion of this testing. The parallel track is we have to be able to manage this, and that has to be done either, you only have two options, through people or through technology. So we're looking at technological types of options, software to allow people to schedule themselves online, to allow them to get results back online, or we'll have to hire a lot more people. Those are the choices.
Well, good. The one recommendation that had the text messages, I think, could help alleviate some of that burden that we're putting on the staff right now. So I appreciate that. Thank you, Mr. Chairman. I appreciate it.
Okay. Commissioner Cruz.
Thank you. This is a lot of information. Thank you so much for being here today. I guess a couple of questions would be, if with the number of tests that are recommended for per 100,000, so currently you're stating it's 22,340, or excuse me, 2,234 in Sedgwick County. And these two options, Wichita State, 5,000 per week, Ascension 5,400 per week. Do you know if there's any indication that Wichita State would be looking to do more nationwide, or would they be looking to do any sort of national kind of partnering? Would the priority be here for either of these? Because we are looking into doing something in the sense of testing. I know Johnson County is not looking. So could you speak to that a little bit? And maybe you don't know the answer, but that's a question that I have as far as keeping it local first, prioritization of Sedgwick County residents.
Sure. According to both applications, both clearly indicate that they're proposing this would be for Sedgwick County. I could ask absolutely the question of if they're interested in proceeding. I don't know enough about the CARES Act to know if that is a possibility. My understanding is that it's for a specific community, for your specific county, so it might be state. That is a deficit of my knowledge. I don't know.
So the other question would be, I know that Via Christi has satellite locations. They're kind of built up already. How do you find that could come in handy as far as collection sites? Because I didn't really see that listed here in their proposal as far as the physical locations they have, access to getting in. So I guess that's a question I have. They're already kind of set up to do it with certifications. I mean, they're a hospital system, obviously. And then the last question I have, I don't know if you had
Happy to, yes. So for the location, it was not included. That information was not included. It is AMS Labs. So there is that is a point that we would like to also request additional information. It did not indicate that it was going to be Ascension Via Christi St. Francis or what that plan was. They did indicate as a part of their proposal that they have created a mock plan, a design, but they did not indicate where that would be located.
So, I guess the whole point of this is to have a quick, accurate test and to get results. Do either of these two, from what you've seen so far, fit that? I mean, would you be willing to give us a recommendation? And understanding that there are a lot of questions, but at the end of the day, I think a lot of people are going to say, this is a lot of information, tell us what to do. Can you give us a recommendation? I mean, a quick, accurate test, and how does it relate to the health department as well? Because we're going to be ramping up our testing.
Right. Yeah, it's a great question. I would love to give a recommendation. I would like a little bit more information before I do it, because I can't give you the specificity and sensitivity of the machine that Wichita State has purchased. So I don't know.
Okay.
My assumption is that they're both going to be comparable. And my assumption is that the timeline will be comparable, because even though Via Christi set up, and this is what they do, they also are going to have to purchase a new machine, and it's going to take time. There's a plus with Wichita State in that they've already purchased the machine, and they are proposing a flexible implementation, driving people to their healthcare provider. But there are also advantages of having a drive-through. So there or a walk-through. It's really, at this point, I'm happy to give you a recommendation, but I would prefer to have additional information before I do.
Okay. And then the last part is we had talked, Tom, about a portal. I did see the whole texting component with Wichita State, which is awesome. But was there any talk of some sort of portal if somebody goes and they can log in to see, you order a pizza, when it's in the oven, right? I mean, is there any sort of technology out there that we could consider when we talk about testing, so that, our problems with hiring folks to call people back, and maybe that isn't part of this conversation, but I think it is. I mean, I think people want to know so they can go back to work, and that's really important. So I'd like to ask that question to both of these entities. I mean, the texting component is great, but I didn't see that with Via Christi, so that would be one thing I'd like to know, because sending it to our health department is only going to overload our system even more than it's already overloaded. So that's a question I'd like to ask.
That is a germane question, and I'd like, when Tim gets to the podium later, maybe he could come back and address that particular component of that,
Okay.
what the technology is that we're looking at. I want to go back to either your first or second question on the regionalization of this. And I haven't talked with Ascension, but in discussions with Wichita State, I know they would love to be a regional or state solution to rapid testing. We are all trying to open communication channels to the state of Kansas and talk about a state rapid testing solution. That's dragging just a little bit, so we have to move ahead with a county solution, because that's who we work for, the people of Sedgwick County. But we ought to have one eye also on what the state is doing. We ought to work together as a team. On the CARES funding component of it, our CARES funding for Sedgwick County, and Lindsay can correct me if I'm wrong, but it is for Sedgwick County. So if Butler and Johnson, Butler, Sumner, surrounding counties want to utilize either of these solutions, they would have to come up with CARES funding that they are going to be given of their own. But I think clearly Wichita State would love to be considered as a regional solution to rapid testing, and they would love to be, I think, considered as a state solution, but we're not to that maturity yet on dialogue with the state to move that direction.
Okay. I just want to make sure that, I mean, Wichita State's already purchased the equipment, and so it seems like from this presentation, I mean, the train is going down the track already. So I want to make sure that the money that we are spending here in Sedgwick County that was allotted for Sedgwick County is to take care of Sedgwick County residents first. So that would be my hesitation, I guess. So, but this was great. This is a ton of information to mull over. Is this, and Chairman, is this is a receive and file?
That's correct for
Okay.
today, ma'am. And then I think if Dr. Ablah can get her questions answered between now and next week, then the next special meeting, I think we'd really like some direction from Commission on what to move forward with under the current state of technology.
Right.
Remembering, again, this is so fluid, technology can be radically different in 60 days. And so if you just think about the pot of money we've set aside for testing, these solutions, what Sedgwick County has moved toward, and what either of these solutions would provide or within our budget, and leave extra money because we have to pay attention to what the next technology is on testing. It could be totally different in 60 days.
I'm sorry, I have one more question. Just about saliva testing, do you see, so there were a couple of places that were approved for emergency use of this test. Do you see anything coming down the track as far as it being, becoming a gold standard? And what is the rate in which it would become like a gold standard? Can you speak to saliva testing?
I can speak a little bit about saliva testing. There are three entities that have received approval, the temporary approval, emergency use approval for saliva-based testing, and their data are pretty solid. However, and that's on their materials. When you look at the research that has been done, there's been a meta-analysis, meaning all of these studies, looking at all of the data and basically melding the stats together to figure out what's the average, for instance, response, and the sensitivity and specificity is significantly lower than the PCR analysis for viral. So it is with the nasopharyngeal. So it is a little tricky. It is definitely of interest because it is a lot less invasive, and it is probably going to allow for other people to get tested because it's not as invasive. But the science is rapidly advancing. And so it is not on the approved list at this point, or recommended list, for Centers of Disease Control as a collection mechanism. But I can see that would be something that's going to turn.
Do you know how quickly it will turn?
No, I don't. I will try and rub my crystal ball a little bit harder tonight, see if I can.
Let me have it when you're done.
You got it.
Thank you.
You bet.
Okay, Doctor, well, thank you. I think that you can tell that the commission is eager to allow you and the staff to get more information, get these few questions answered. If you did simple math, your last slide, 2,200 tests a day, basically 10,000 a week, and in raw numbers say if both of them were in place, that would be 10,000 a week. So yeah. It could almost be argued that we should do both, but that's 30,000 feet comment. The other comment I would have for Lindsay and our staff is that we ought to communicate with the state Spark committee, because if in fact we do help other counties regionally, as been pointed out, I think the state should be participating through their counties or however they want to do it. I don't know who would be the best deliverer of that message. I would be glad to talk to some members of the Spark Committee about that, if that would help.
Lindsay and I had a sidebar going. She's going to, when she gets to the podium, she'll talk about Spark money
Okay.
designated for testing. But to answer your direct question, Commissioner, I think that should, anything that any of the commission could do to help with the facilitation of that discussion would definitely be a
Okay,
benefit.
okay, thank you. Thank you again, Doctor. Appreciate your time. You spent a lot of time on this and appreciate it very much.
Sure.
Okay,
Receive and file, please, sir.
yes, motion to receive and file, I'll make that motion.
Second.
Been motion and seconded to receive and file this report. Any other comments? Being none, Madam Clerk, call the roll.
Commissioner O'Donnell. Commissioner Dennis. Commissioner Howell.
Aye.
Commissioner Cruz.
Aye.
Chairman Meitzner.
Aye.
Okay, and that brings Lindsay up now.